We should take note of them. There will be a time for us to ask questions afterwards. Uh, our speaker for today is Dr. Harpreet Hyare, and she is a consultant neuroradiologist from University College London. Without wasting much time, I will quickly take her citation and then I will invite her to begin her lecture. Okay, so I encourage us to feel free to drop our questions in the chat box, and then it will all be taken at the end of the lecture. And for those just joining, as you join, I encourage us also to mute our mics so that there's no interference. So just a brief citation on Dr. Harpreet Hyare. She's a consultant neuroradiologist and honorary associate professor whose work focuses on quantitative MRI and artificial intelligence to improve the diagnosis, monitoring, and stratification of neurological diseases, particularly neuro-oncology and brain tumors in teenagers and young adults. She leads multidisciplinary research integrating neuroimaging with genomics, pathology, and clinical data, and has contributed to the development of explainable and equitable AI tools for brain tumor imaging. Her research includes tumor segmentation, perfusion imaging, microstructural MRI, and high-dimensional modeling, with publications in journals such as Nature Medicine, Brain and Neuroimage Clinical. She also holds national and international leadership roles in neuroradiology and MRI, and recently completed her executive MBA at University College London's Global Business School for Health, reinforcing her focus on innovation and translation. Teachers, ladies and gentlemen, colleagues, join me in welcoming our speaker for this evening, Dr. Harpreet Hyare, as she leads us through this evening's session. Dr. Harpreet, you have the floor, please.
Thank you very much for that very kind introduction, and thank you to Godwin and to Adesola for inviting me to give this lecture today. I think I've just checked that you can hear me clearly, and I'm going to share my slides shortly. So greetings from London. It's 5 o'clock here. I think it's slightly later in Nigeria, and it's a real pleasure to speak to you today. So hopefully you can see my screen. Can someone just nod? Yeah, I've had a thumbs up, so we're fine. While I'm presenting, I can't actually see the chat. So if you don't mind just saving your questions for the end, I'll try and finish in about 40 minutes, 45 minutes, so we've got some time at the ends. And please do, link in with me. I'll be in Africa, in Cape Town for the ISMRM meeting. So hopefully I can meet many of you in person. Okay, so what we're going to do in the next 45 minutes or so, I'm going to show you, I gather that most of you are not neuroradiologists, but you do neuro reporting. I'm going to just show you a standard framework for how we evaluate brain tumors. I'm just going to move my screen here at the bottom. Yeah, perfect. And then I'm going to show you how to recognize key radiological differences in adult CNS tumors. My background is pediatric and adult, so teenage and young adult is my area of specialism, but it's too much beyond the scope of this lecture to include a lot of pediatric work in this lecture. So I'm going to focus around what we normally see in our adult MDT, which is gliomas, all the different subtypes, meningiomas, CNS lymphoma, and metastatic disease. And then this will be mainly a clinical lecture, but at the end, I'll just give you a taste of some of the advanced imaging and some of the work that we're doing at UCL. So our systematic approach has quite a few different aspects, and we're going to go through each one in turn. So what's the most important? Well, actually, is age. The age is one of the most important things to look at when you're reporting an MRI scan in a patient with brain tumor. So this is some data from the CBTRUS. This is from the US. And just to show you that the epidemiology of brain cancer is very different in the different age groups. So, for example, in the very, very young patients, we see high prevalence of gliomas and other tumors. And actually, we see very little, for example, of pituitary tumors. But as we increase with age, we can see actually pituitary tumors become much, much more prevalent. So when we're looking at the older teenage age group, we've got to know what the incidence is compared to the younger pediatric age group, and also compared to adults. So in adults, for example, the most common brain tumor, which increases with age, is actually meningiomas, which is something we see very, very rarely in the pediatric age group. And in terms of the primary brain tumors in adults, it's actually GBM. It encompasses 50% of the intrinsic gliomas in the adult population. So the most important thing to look at the scan is the age, the date of birth, and the age of the patient before we look at anything else. Okay, so then what? Then actually, it's the localization of the tumor. So we've got to work out where in the brain this tumor is. So one of the most important things is this tumor within the brain parenchyma, or is it outside the brain parenchyma? And this tells us completely a differential diagnosis. So intraaxial tumors, we're thinking much more about the gliomas, the CNS metastases, CNS lymphoma, whereas extraaxial tumors, we'll be thinking more about meningiomas and schwannomas. And how can we see this? Well, the T2 and the flare are really important sequences to have here. So this is an example of a meningioma, convexity meningioma. And what we're looking for is displacement of the brain parenchyma around an extraaxial lesion. And sometimes we see this little CSF cleft here, showing the separation, the cleavage of the tumor from the brain parenchyma. And sometimes we also see displacement of a vessel, and that gives us a clue this is an extraaxial tumor. And here on the flare, we can see very nicely on the normal side, we can see the high signal from the cortex compared to the white matter. And here where this tumor is, we can see this high signal is pushed or displaced medially by this particular tumor. So this tumor is from the outside pushing in. This is a meningioma. We compare that to an intrinsic tumor. This is a glioblastoma. And we can see that actually those brain parenchyma all the way around this lesion on the T1 post contrast. And then on the flare, we can see the cortex on the normal side here. And actually, we can see that the cortex is enveloping this tumor. So this tumor is arising from within the brain parenchyma, not from the outside pushing in. And this is a GBM. So it's really important to use our diagnostic imaging, use all our sequences, particularly sequences that show the grey-out matter differentiation really, really clearly to help us localize the tumor. And that sets us off into our differential diagnoses. And then the other localization is the anatomical localization. So, for example, astrocytomas tend to be commonly in the frontal lobes. When we see a tumor around the hypothalamic pituitary axis, we'll be thinking more about pituitary tumors, craniopharyngiomas. It's more common sense. When we see something in the pineal region, we'll be thinking much more about, pineal tumors, pineocytomas. And of course, in children, particularly in the posterior fossa, there'll be certain tumor types, for example, medulloblastomas, ependymomas, pilocytic astrocytomas, that are much more common in cerebellum, the posterior fossa, than they are in other parts of the brain. So having that understanding, that knowledge of the anatomical localization can help us differentiate or certainly narrow down our differential diagnosis before we start looking at tumor characteristics. So just to reinforce that, this here is a suprasellar tumor. This actually is a suprasellar meningioma. You can see this enhancement along the diaphragma ocelli. And then the differential here is craniopharyngioma, pituitary adenoma, and erasthes cleft cyst. Also, looking at the chiasm, also optic chiasm gliomas can also occur in this location. The cerebellopontine angle, we're thinking, like you can see here, this is a really nice example of an extraaxial tumor where we can see deviation of the brain parenchyma and the blood vessels and the CSF cleft. So this is an extraaxial tumor. So in this region, the cerebellopontine angle, we're thinking schwannomas, meningiomas, epidermoids, and arachnoid cysts, and paragangliomas. And this was a schwannoma. And then finally, in the pineal region, then we're thinking much more along pineal-related tumours, so germ cell tumours and pineal parenchymal tumours, but also tectal plate gliomas, because tectal plate tumours can be exophytic and can extend into the quadrigeminal cistern, and also you can get meningiomas of the tent that can be exophytic and also extend into the quadrigeminal cistern. So we've gone through our age, we've gone through our localization, intraaxial and extraaxial, and then we come to our CT and MR characteristics. So what do we need to understand from our MRI? Well, there are a few things that are important. Does the lesion have fat? Is there calcification? Is there a cyst? Is there some areas of high density? And then we look at the T1 and the T2 signal. And then we also look at our diffusion, which can give us an indication of cellularity. And then we can, in our routine practice, we have perfusion, MR perfusion, and MR spectroscopy as our standard sequences. But if that's not the case in your practice, we'll go through that in a moment. So this here is, you can see here, a pineal region tumor. You can see here on the susceptibility weighted imaging, there is actually some signal dropout. So there is some inhomogeneity here. So there could be some calcification here, or there could be some fat. And then when we look at the T1 pre-contrast, we can see this lesion has a small area of fat density. So actually this turned out to be a teratoma. So we're putting together all our sequences. So our localization is this is a pineal region. We're using our susceptibility weighted imaging to understand whether there's calcification, and then we're using our T1 weighted imaging to understand whether there's fat. And all these intrinsic characteristics of the tumor can localize us and narrow our differential diagnosis to what this was, which was a teratoma. It's really important to look at the CT. So whenever I do my MDT, I always make sure I look at the CT first before I look at the MR. This is because we can get so much information from the CT. So calcification is the number one thing that we can see on the CT that's much more sensitive than MR. So this is a typical example of an extraaxial meningioma. You can see, even on the soft tissue weighted images, you can see that sort of very coarse calcification. And on the bone windows, you can see that calcification. And here you can just make out on the MR, this thin rim of enhancement. This is a convexity meningioma. And meningiomas, 25% of them have calcification, but also other tumors. So in the pituitary region, craniopharyngiomas are 90% likely to have calcification that can help you differentiate it from a pituitary adenoma. It's important, people don't often realize that the intraaxial tumors like astrocytomas, oligodendrogliomas, and gangliogliomas can all have calcification, and which is quite high in gangliogliomas. Oligodendrogliomas you may well be aware of. So calcification can really help you narrow down your differential. And then the other thing CT can give you is whether there's fat or hemorrhage. So fat, this is a really nice case of fat density in the region on the midline. And when we did the MR, we can see actually this is a lipoma. So this is actually a corpus callosum lipoma. It's not a lesion, and this is a normal variant. But fat within tumors can tell you whether this is something like an intracranial dermoid cyst. And the previous case I showed you, where it was a teratoma, a fat-containing teratoma. And then the other thing that the CT can tell you is hemorrhage. So this is a patient who presented through ED with a large parenchymal bleed, and typically glioblastoma can also present with hemorrhage, but also metastases can as well. And actually, when we looked at the patient's previous imaging, we saw this tiny little lesion here, and the patient was known to have renal cell carcinoma. So actually, this tiny lesion caused this massive hemorrhage. And this hemorrhage was due to the renal cell carcinoma metastasis. So they can present with hemorrhage. So it's important that you know that, and particularly the mucinous adenocarcinomas tend to present with hemorrhage. So what's our standard sort of protocol for looking at our brain imaging? And this is what we do at UCLH. So this is, we do a T1 pre and post contrast. We have a T2 axial. We do a 3D flare. We do DWI with ADC map, and we do some sort of heme sensitive sequence. So we do SWI, but some centers do T2 star. And even though these are all in an axial plane, actually, the way we look at these images is very much, in a very interactive 3D way. So this is, I'm sure like as you in your practice, you look through the scan, you scroll through, you try and identify the lesion, you look for second lesions. For me, the T2 axial is the most important sequence because it shows everything. You see your vessels, you see your edema, you see the lesions, you see the extracranial parameters. DWI, as you know, we'll go on to that in a moment, but in this patient, the rim of the tumor shows high signal on the DWI and low ADC. So it's a very cellular tumor. And then the flare can give us information about the edema and the mass effect. And this is the phase contrast for the SWI. And you can see that this lesion was very hemorrhagic. So you have foci of susceptibility artifact. And then finally, we come to the T1 post contrast. So most clinicians go straight to the T1 post contrast, but we don't need to do that. We're radiologists and we're neuroradiologists. And look, we can spot some extra lesions there that we maybe didn't see on the T2. So there's an extra third lesion in addition to those big lesions that we saw on the previous imaging. So, very interactive, scrolling, NPRing, looking different dimensions, looking in different planes, and using all the sequences to build your picture of the characteristics of this tumor. So the T2 I said was, the most important sequence for me. And oh gosh, I just didn't switch off my phone, so apologies for that. Um, as we know, the T2 image is due to spin-spin relaxation. So tissues where the protons are very, very close together will lose the signal more quickly. And tissues where the protons are far apart will retain the signal. So in a T2 weighted image, where the protons are far apart in fluid, the signal's retained. And where the protons are very, very close together, like in the bone, we see a loss of signal very, very quickly. And if we then time our acquisition at a certain time point where there's different signal intensity or different dissipation of signal within the different tissues, that's how we get our contrast. So this is an example of a GBM, IDH wild type, and you can see that on a T2 weighted image, this is high signal. This is because the tumor actually is very disorganized tissue compared to the white matter, which is very, very organized. So the white matter loses the signal, the T2 signal quickly, but in the tumor, which is disorganized tissue, near angiogenesis, uncontrolled tumor proliferation, the signal's retained. So on the whole, most tumors will be bright on a T2 weighted image. So this is an array of sort of classic tumors we see through our MDT. So our three most common gliomas, IDH mutant 1p19q code-deleted oligodendroglioma, IDH mutant astrocytoma, and IDH wild-type GBM. And we can see that the astrocytoma, the signal intensity is very homogeneous, it's very well defined. Oligodendroglioma is well defined, but the signal intensity is a bit more heterogeneous. And then on a GBM, on the T2 weighted image, you've got very heterogeneous signal intensity. But on the whole, you can see that the T2 signal is brighter than brain parenchyma. We then look at our CNS metastases. We can see here is quite very low signal intensity in the rim of this metastasis. And we can see the bright signal of the edema. And our CNS lymphoma is very tightly packed cells. So the signal is lost very quickly on a T2 weighted image, and we see low signal intensity here. So this tumor is much more well organized than our gliomas. And finally, this is our meningioma here. And on the T2, you can see that deviation of the blood vessels and the brain parenchyma. So we know this is an extraaxial lesion. So our flare is an inversion recovery sequence. So we invert the signal, and then we sample our image when the signal from CSF is 0. So you can see here the signal from CSF is 0, but essentially this is a T2 weighted image. So our white matter is very low signal, our grey matter is slightly brighter. And because it's a T2 weighted image, our signal intensity from the tumour is also bright. The advantage of the flare, though, is that tumors that are very close to the CSF, we can see the connection, we can see whether there's any ependymal invasion. And also here with the hydrocephalus, we can see the transependymal spread of CSF. So the flare is very good for tumors that are very close to the ventricles. It can help differentiate the tumor from the signal intensity within the ventricular system. So back to our array of tumours, we can see all our gliomas are bright signals, slightly heterogeneous on the GBM. And we can see that the edema very clearly on the flare, and we can see this sort of mixed signal intensity of our CNS metastasis. Our lymphoma is also a little bit brighter than white matter, but not as bright as the gliomas, because again, it's that organized, packed tissue. And we can see very nicely our meningiomas. In fact, I really love this sequence of extraaxial lesions because the fact that we've nulled the signal from the CSF and from this is a fat stat sequence, this flare sequence, and from the bone marrow, we can really see the extraaxial lesion very, very clearly because there's no signal from the CSF surrounding it. So then our T1 relies on longitudinal magnetization. So we're looking for the buildup of the signal within the brain parenchyma. So slightly different to our T2 in that the closer together the protons are, the more quickly the signal will build. So here, our corpus callosum, our very nicely tightly packed white matter of our brainstem, the signal builds very, very quickly. And we see bright signal when we sample our T2 weighted image in compact tissue. And then in CSF, where the protons are further apart, the signal builds less quickly. So we see low signal. Can anyone spot the tumor? Well, I can tell you the tumor's here. It's this low signal area within the cerebellum. So you can see that the disorganized tumor disrupts the highly organized brain parenchyma. So we don't see that bright signal that we see in the superior vermis, and we see that low signal intensity. So that's what we see in our tumors. So it's a bit hard to see oligodendroglioma, but it is low signal. We see our low signal astrocytoma. The GBM is bright signal, and we'll come on to that in a moment. And then low signal, very low signal in our CNS lymphoma, and then our meningioma again. So the bright signal, this is where our T1 pre-contrast is really, really helpful. If we see bright signal pre-contrast, that can make us think of extracellular methemoglobin, so blood products. Here, this is a resolving hematoma, actually from that same renal cell carcinoma tumor I showed you. Here, this is actually a metastasis from melanoma. So the melanin itself can actually be bright on a T1 weighted image. And then, of course, I showed you that fat from before. So going back to our GBM, actually that bright signal is from the hemorrhage within the GBM. And I told you before that hemorrhage is very common in GBMs. So again, that helps us with our differential diagnosis. So diffusion, very important sequence in neuro-oncological imaging. So this actually is a stroke. This is a left MCA territory stroke. And you know that DWI was really developed to detect cytotoxic edema in stroke. So how does it help us in brain tumors? Well, actually, it can be really helpful. So this is a ring. This is a sort of solidly enhancing lesion close to the ventricles. We can see that it's quite low signal on the T2, and on the DWI trace weighted image, it's very bright and it's very low ADC on the ADC map. And the theory is that the more tightly packed the cells are together in the tumor, the less able the water is to flow in the extracellular space. So there's restriction of water motion in the extracellular space, and that leads to low ADC. So the more cellular the tumor, the lower the ADC. And this actually was a CNS lymphoma. So going back to our array of tumors, I'm showing you the ADC map now. A DWI trace weighted image is a T2 weighted image. So anything bright on the T2 will be bright on the DWI. So we must always look at the ADC map to actually decide whether what we're seeing is a truly restriction of water motion. So our tumors, our gliomas, actually show facilitated diffusion, free diffusion, because we've got this disorganized tissue compared to normal brain. So there's more sort of water motion in the extracellular space. But our CNS metastasis here is very cellular. You can see it's very low signal on the ADC map. This is the enhancing peripheral rim of the tumor. And then we can see our CNS lymphoma is very low signal on the ADC map. So that supports our hypothesis that actually, very cellular tumors have low ADC. So it can really help us in diagnosing CNS lymphoma and differentiating it from gliomas, and our meningiomas intermediate signal intensity. And then finally, we have our heme sensitive sequence. this sequence relies on inhomogeneity in the magnetic field. So any pathology that causes inhomogeneity will cause signal dropout, and we can leverage this to our advantage in brain tumor imaging. So this is actually a patient with cerebral amyloid angiopathy with a lobar hemorrhage, and you can see these very tiny foci of signal dropout, which are basically microhemorrhages. So how does this help us in brain tumors? Well, in brain tumors, what we can see actually is, for example, in the GBM, we can see these foci of signal dropout corresponding to the intralesional hemorrhage. In our metastasis as well, we can also see this is a hemorrhagic metastasis. Then we're thinking instantly about the mucinous adenocarcinomas. CNS lymphomas very rarely have hemorrhage. And then this area here of low signal intensity in the meningioma corresponds to calcification. So it's a really important sequence for neuro-oncological imaging. So finally, we get to contrast enhancement. So even before we get to, most clinicians, like I said to you, just go straight to the contrast enhanced scans, but we're using all our other strategy, our age, our localization, our CT and MR characteristics before we get to the contrast enhancement. So what does this look like for us? So oligodendrogliomas and IDH mutant astrocytomas typically are very low, poorly enhancing. Our GVM shows florid, avid enhancement. Our CNS metastasis shows peripheral rim enhancement. And our CNS lymphoma shows very avid, homogeneous enhancement. And our meningioma also shows very avid enhancement. So the contrast enhancement is also really helpful for CNS dissemination. So we've spotted our lesion, we've characterized it. Now we want to know, is this lesion anywhere else? And to do full staging, we must always image the spine. So for CNS dissemination, we need to know whether the lesion is single or multifocal. You can get multifocal GBMs, but generally, if you see more than one lesion, then you're thinking instantly about metastases. This is a patient with breast metastases. But not all lesions enhance. So this is a patient with breast metastases, and this lesion here enhanced, but these tiny little T2-weighted cystic lesions were non-enhancing. So always check the T2 when you're evaluating metastatic disease. Metastatic disease can also be leptomeningeal. So this is a patient with a breast cancer patient with leptomeningeal disease. What we do, and some centers also do, we can do a flare post-contrast. This is another patient with leptomeningeal metastatic disease, but you can't see it very well on the T1. But actually, when you do the T1 flare post-contrast, you can really see that high signal along the sulci. So this is a flare post-contrast, and we can see that leptomeningeal disease much more clearly than we can see on the T1 post-contrast. So we do this sequence, this contrast enhanced flare in selected cases where we're suspicious for leptomeningeal disease. And this is another patient where we must always evaluate along the dorsum of the brainstem, and also can you see the upper cervical spine? And when we actually did the full CNS staging, this is a patient with germinoma. There was actually contrast enhancement along the conus, and you can see the nerve roots of the chorda equina. So we must, in every tumor, we must always evaluate for complete staging, looking for CNS dissemination within the spine, and particularly certain tumors, like, for example, metastatic carcinoma, and also for pineal tumors such as germinomas. So those in particular, and posterior fossa tumors, not so much the gliomas, but we tend to do a staging just to at the start, just to make sure we're not missing anything in the spine. And then in some of the pediatric tumors, there are some practice parameter guidelines from the ACR ASNR. They're quite old now, from 2019, but what they suggest is this is a diffusion weighted spine, and this is a cis, heavily T2 weighted sequence. So this is a patient with ependymoma metastases, and we can see this lesion really, really well on the T1 post-contrast, but it's not sure as any other lesions. We do the DWI, and we can see this other lesion here. And then when we do the T2 cis-weighted sequence, we can see there's a lot more little nodularity along the nerve roots of the chorda equina. So actually, this patient had a lot of dissemination. This helps the radiotherapists then they can boost the appropriate areas. And then finally, we want to tell the clinicians whether the surgeons need to be involved. And so mass effect is one of the most important things. So looking for hydrocephalus, this is a patient with germinoma with obstructive hydrocephalus at the level of the aqueduct, and we can see that transepiphyseal spread of CSF. We must also think about uncal herniation. Here you can see the uncus is deviated medially, and here uncal herniation is also midline shift, so some sort of falcine herniation. And so also we must look for downward cerebellotonsillar herniation as well. So we must always tell the surgeons about any potential mass effect. Okay, so we've got our approach now to our brain tumours. We know how to evaluate them, we know how to characterise them, we know how to look for mass effect. But can we sort of get a bit closer to what's happening at a molecular level? So there are lots of things happening at a molecular level within brain tumours that actually we can characterise quite well on MR. So all these cellular mechanisms, there are some things actually we can do already on imaging. So in terms of metabolic alteration, as you know, there's many FDG or many PET tracers that we use in nuclear medicine to characterize brain tumors. So FDG itself is not so valuable here. You can just make out this brain tumor. This was a CNS lymphoma, but because we get such background uptake within the normal brain parenchyma, the tumor to normal brain contrast is not very good with FDG PET. So it's not something we use in routine practice. But what has come into practice is amino acid PET. So there are lots of amino acid tracers, but most of the work published has been with FET. We published with DOPA, F-DOPA, but the beauty of amino acid PET is we have very good tumor to background contrast. Choline used to be in vogue, but is a bit non-specific, and we have new traces coming through all the time. So some of the work that we've done, looking at F-DOPA. So this is a patient with a diffuse scleoma. You can see right thalamic, right hemispheric, not much in the way of contrast enhancement. But when we do our F-DOPA, we can see there's increased uptake within this part of the tumor, which corresponds to the MR perfusion. So we can tell the surgeon to direct their biopsy to that part of the tumor, which we think is more metabolically active. And then also in follow-up, here we can see another patient with a left hemispheric glioma being treated, not much in the way of enhancement, very diffuse. And post-treatment looks very similar in terms of the extent of T2 signal, maybe a little bit more enhancement, but actually when we do the F-DOPA, we can see reduced uptake. So actually there's metabolic response in this patient. We don't do F-DOPA as routine clinical practice anymore at our institution, but what we do is gadolinium dotatate imaging. So this is a really great technique for meningiomas. So when a patient's had a meningioma resected and we have a lot of background enhancement and we're not sure whether there's any residual, we often do a gadolinium dotatate imaging, and that can show us that the enhancement, actually part of it is actually residual tumor. So then the radiotherapist can adjust their radiotherapy planning to take that into account. And in terms of tumor heterogeneity, there's a lot we can do in our standard of care. So this is a DWI image showing that this part of the tumor, the anterior part, is actually a little bit more cellular than the posterior part. We've got MR perfusion, all types of MR perfusion, DSC, DC, and ASL. And we also have MR spectroscopy that can help us look at the tumor heterogeneity. So this is a patient with a very diffuse glioma, sort of non-enhancing. And what these studies show, the meta-analyses show, is that there is a correlation between ADC and tumor cellularity. So the lower the ADC, the more cellular the tumor. So what we can see within this tumor is this part, this anterior part, shows bright signal on the DWI and low ADC. So this part of the tumor is much more cellular than the other parts of the tumor. Then when we add in our MR perfusion, there's lots of evidence that shows that like this is DSC perfusion, that the perfusion parameters correlate with tumor grade. So we can see that in this more cellular part of the tumor, there's actually increased RCBV, so increased blood flow to that part of the tumor. But this part of the tumor posteriorly, different level, which looked a bit bland on the ADC, we can see actually there is some uptake in that part of the tumor as well. So it's very sensitive for helping us understand the tumor heterogeneity. And finally, we can do MR spectroscopy. So this is a single voxel spectroscopy, which shows your typical tumor profile. So we use creatine as our ratio marker. And in this case, we can see the NAA is decreased, as a neuronal marker is decreased, and the choline marker is elevated. And when we do our multivoxel spectroscopy, what we normally use, most of the meta-analyses show that the choline to NAA ratio is the most sensitive. We can see that in the medial part of the tumor, the choline to NA ratio is high. So we can see that, map that heterogeneity, metabolic heterogeneity of the tumor. In terms of MR perfusion, we have probably the most common in clinical practice around the world is DSC perfusion. It's very short imaging time, but very prone to susceptibility artifact and low resolution. DCE has a much higher spatial resolution, but it takes a longer time, and we need to do offline modeling. And a technique we're looking into a lot more now, certainly at our institution, is arterial spin labeling. And the beauty of that is there's no need for exogenous contrast. So we can excite the blood vessels in the neck, wait for the excited protons to enter the brain, and then image without the need to give any contrast. So it's excellent for pediatric patients. But at the moment, the signal to noise ratio is low. So in terms of RCBV, that's probably the most widely used. The meta-analyses have shown that, and this is what we do at our institution, we do a ratio of the enhancing part of the tumor or the non-enhancing part to normal appearing white matter. And this can usually, what the most of the papers say is a cutoff of around 2. Supports a higher grade tumor, so a higher grade diagnosis, grade treatable. Just the light switched off in here, so I'm just going to wave my arm around and just get the light back on, so I'm not sitting here in the dark. There we go. Apologies for that. And then for DCE, the most commonly used parameter, there's some controversy about this parameter, but mainly people use the K-trans and basically a cutoff of 0.04 is supportive for higher grade. And for ASL, an RCBF again are greater than 2. And again, ASL, we normally do a ratio of the tumor to the normal appearing white matter. For MR spectroscopy, there's quite a few meta-analyses, and actually MRS only has a moderate diagnostic performance in distinguishing high grade from low grade tumor, but the choline to NAA is the most sensitive. So here you can see it's quite a large tumor, and on this multivoxel spectroscopy, we can see this medial part of the tumor actually has a high choline to NAA ratio. So they're going to biopsy this tumor, the surgeons can be targeted and guided by the choline to NAA ratio. So in our institution, and this is different to other institutions, but what we use the advanced imaging for is number one, to differentiate tumor from mimics. So differentiating it from inflammatory lesions. But we use the spectroscopy together with the MR perfusion because most lesions, MR spectroscopy is very sensitive but not specific. So we have to put the two together if we're going to differentiate tumor from mimics. We use it to evaluate treated tumor to try and diagnose whether there's inflammatory change or whether the patient's gone on to tumor progression. We can use it for 3D evaluation of tumor heterogeneity, as I've showed you, for targeting biopsies. And we can use it to actually understand the molecular genetics. So in the last 5 minutes or so, I just want to talk about a couple of sequences that we're developing, a little bit of research. So I've shown you DWI, and I've shown you how valuable it is in brain tumors. So here's an example of a GBM, which is necrotic, and you've got this peripheral enhancing rim. And the enhancing rim shows restricted diffusion on the DWI. So we're looking at that increased cellularity and that restriction of motion in extracellular space. But when we're modeling the diffusion, we're not taking into account the blood vessels. So all tumors will have a blood supply, and this disorganized neoangiogenesis blood supply is not being modeled. And this is where a new framework for modeling diffusion, water diffusion within brain tumors called Verdict is being developed at UCL, and we're applying to brain tumors. What this model does is it's a 3-compartmental model. So we model the cells as spheres, but we also model the vasculature as sticks. So this is the stick and ball model. So it's a 3-compartmental model. So we've got the extracellular space, we've got the intracellular space, and we've got the neoangiogenesis, the blood vessels. So we initially did some work in mice models. This is a mouse model looking at the growth of the tumor, and a control just looking at tumor evolution, and then a treatment arm with temozolomide. And just to show you on the structural MRI, the native or naive tumor was growing quite rapidly, and we started to see a slowing progression of the tumor growth at about 6 days. Using ADC, we saw that separation about 3 days, and then using the verdict parameters, we can see separation almost immediately. So we really think this could be a very sensitive early biomarker. And this, what we've done is combined verdict with NODI. Some of you may have heard of the NODI sequence. So we can model water diffusion in the normal brain, normal looking brain, and then we do verdict within the actual brain tumor. And it's the FIC parameter, which corresponds to nucleic density. And we can see that heterogeneity within the tumor that we just couldn't see on the ADC map and the DWI. And then what we've done is we've doing a study with Kubrick, with Marco Palumbo, where we're actually combining the MR spectroscopy and the diffusion together to do something called diffusion-weighted MR spectroscopy. So what we do is we acquire the spectra at different diffusion values. And by doing that, we can model the diffusion of the metabolite. And so we did a study with a control voxel and a voxel in the tumor. And what we showed was that in the tumor voxel, the diffusion of the NAA was decreased compared to control, and in the tumor voxel, the diffusion of choline was increased compared to the control. And we think this is because the tumor cells are large microglial cells, so there's room for the choline to diffuse, whereas for the tumor, the neuronal cells get atrophied or they get invaded by these very large tumor cells and microglial cells. So we see that reduction in the diffusion of the NAA due to the invasion of the normal cells by the tumor. So we've got that neuronal atrophy compared to glial activation. So we're moving now away from looking at sort of water diffusion, looking at metabolites, to actually understanding the underlying cellular morphology. And another technique we're looking at is sodium imaging. So sodium imaging looks at the exchange of sodium across the cell membrane. And there's quite a few centers now looking at sodium imaging. And what we think is that the disruption in the membrane due to the turnover causes increased sodium exchange. And we see that in the tumor by having higher signal. And what we're doing now is trying to combine the sodium with the verdict to work out how much of the sodium is intracellular and how much of it is extracellular, and see whether that can give us any extra information about the tumor. So finally, a little bit of work about the AI stuff we're doing. So what we're doing something called graphical modeling, where we're combining imaging data with genetic data and clinical data. And this is, those of you who've been to London, you'll know this is a tube map. And what this graphical model allows us to do is put bits of data together and to see the relationship between the bits of data. So, for example, Baker Street has lots of connections. It's a very important hub. Compared to, for example, Lancaster Gate, that hasn't got much connections, so it's not a very important hub. So the more important the connections are and the data, the increase in that hub, that's called a node, and the connection between the different parts of the data is called an edge. And what we can do is we can identify communities of interrelated data, and this can help us build a picture, completely data-driven, and can answer the question that we're answering from a large data perspective. So what we've been doing, we've been applying this in graph lesion deficit mapping of fluid intelligence, and we've also applied this to look at all the different individual molecular genetics in brain tumours to give us a much more accurate picture of survival compared to the standard categories of the three main categories of glioma. And What we've done is we've collated our own institutional data set of 7,809 histology samples, and that's over 4,000 detailed imaging data, and also longitudinal data. And what we've done is built a pipeline where we can curate all the images, we can super resolve them, so we can put scans from 3T scanners and 1.5T scanners all together by reslicing them in the same space. And then we apply a segmentation model to extract the brain tumor, and then we can do radiomic feature characterization. And then we've even been able to do this. My clever PhD student was able to develop a model that could do this even when some of the sequences are missing. Because those of you who work with BRATS data know that you need a full data set, but actually clinical data is not like that. Sometimes the patient moves, sometimes you can't give contrast. So he developed that, and then we developed an automated feature extraction pipeline. And then we applied this to our data set of brain tumors, and we can map the most frequent parts of the brain. And then when we correlate that with our histology, we can see that, our GBM IDH wild types tend to be more deep in the parietal lobes compared to our oligodendrogliomas, which are frontal, and astrocytomas, which can be temporal and also frontal. So this is completely data-driven, and we're trying to use this now as a non-invasive diagnostic tool. And then what we're doing now is trying to build with these graphical models is to combine routine data with clinical data with imaging and histology, and use that to try and stratify patients for outcome prediction and to underlie and cover underlying disease mechanisms. So hopefully, I'll stop talking now and you can all talk, but hopefully what I've shown you is like a sort of a very systematic approach to how we interpret a brain MR for brain tumor imaging. I've shown you the advantages of each of the conventional MRI sequences. I've shown you how we used advanced MR perfusion sequences, and I've touched upon metabolic imaging. And then I've shown you some of the new techniques that we're investigating at UCL that will hopefully be coming on the horizon and hopefully into clinical translation. So thank you very much for you to listening and to all the people I work with over at UCL and in the UK. Thank you.
Thank you. Thank you for the brilliantly delivered lecture. It was quite instructive. The floor is now open for questions. I did not see any question in the chat box. So if you have any question, you can just raise up your hand electronically and you'll be granted the permission to speak. But before then, let me just ask two questions just to prepare the ground for those that will be asking questions. So my first question is, when you talked about CNS dissemination, we're talking about conditions that can cause drop metastasis. At that point, you talked about classification of tumors. What classification exactly are you talking about? We know that in talking about tumors, sometimes they talk about the WHO classification. I don't know if that's what you're referring to, because in other parts of the body, they talk about TNM classification. So what classification were you talking about at that point? That's my first question. Then when you talk about metabolic imaging and sodium imaging, is there a contraindication to these images? If a patient, for instance, have hypernatremia, will that affect the study? Or say a patient, for instance, with diabetes.
Yeah, okay, thank you.
Will that
Really good
patient be, would such a
questions.
patient be suitable for metabolic imaging? Yeah, thank you.
Yeah, no, thank you very much. They're both really, really great questions. So the first question, if I say classification, maybe I didn't clarify that. What I meant was we need to do the spinal imaging for complete staging. So in the same way that you stage a tumor in the body, you have to do a whole body scan. We have to do the same for the brain. So with brain tumors, we must image the spine for complete CNS staging. I mean, if I said classification, that was an error on my part. It's to stage the tumor. So, like in the body, we have a stage 1, 2, 3, 4. In the brain, we've got to image the spine as well for staging. Does that answer your first question?
Yes, please.
Yeah, the second question, as far as I'm aware, so I know for FUG PET and for certain dynamic imaging, you've got to be aware of the patient's blood flow, the blood sugar, but there's no contraindication for sodium imaging for patient with diabetes, as far as I'm aware. In terms of high serum sodium, that's an interesting one because I don't know the answer to that question actually. So that's something I'm going to ask my physicists. I would have thought the way the quantification's done, I would have thought we don't routinely take blood samples when we image these patients. So the way the quantification's done is using a phantom. So what we do, we have, I didn't show you on these images, but the patient, when we image the patient, we have a phantom with different sodium content, four different sodium concentrations that we image at the same time. And those sodium concentrations are known. So when we do the quantification for the parameter map, we basically, in a very simple way, we take the signal from the brain that's been measured with the sodium, and then we do a ratio or a correlation with the phantom, where we have a known concentration of sodium. So that's the way that we do it. So it's nothing to do with serum sodium. Is we quantify using the known sodium concentration in the phantom. But I'm gonna ask the question to my physicist just to see whether serum sodium has been measured before, whether there's any papers on it, and whether it will affect the actual sodium quantification. So thank you for raising that.
Thank you. Dr. NK, I can see that your hand is up. Can you unmute yourself and ask your question, please? Thank you.
Okay, thank you for the beautiful presentation, really exhaustive. I want to find out, with all these modalities of imaging the brain for tumor, it's like most of them are quite specific. I want to find out where does it leave us with histology? Where is there any need for histology? That's my question.
I think there's a lot we can tell now from the imaging. As I showed you, we can understand or we can make presumptions around cellularity, tumor cellularity. We can make inferences around the metabolic activity. But I don't think we've yet got a reliable way to non-invasively measure tumor histology. We just haven't got the resolution or sensitivity. So I can not foresee a situation where a patient will be treated without tissue. I don't think that will ever happen. But what the imaging can do is maybe triage the patients, so that's what we try and use it for. So we have a patient, I showed you, some of these tumors don't enhance, but, does it mean it's high grade or low grade? We don't know. We do all the advanced imaging. Actually, it's a high grade tumor. This patient needs to have surgery next week. They need to have their biopsy quickly. So I think that's where the value is. It's in the triaging of patients by being able to differentiate high from low grade tumors. And then also then in the follow-up, So I don't think we're there yet. I don't think we'll ever be there. But histology, tissue will always trump everything. It's the gold standard. But I think the imaging can be very valuable, reduce uncertainty, speed up triaging, can give us some indicators of whether, a tumor will respond or not respond, whether we should switch to second line, third line agents, etc.
Okay, thank you for answering that question. There's a question in the chat box from Dr. Jonathan. He says, so for every patient with suspicion of brain tumor, do you do two modalities, that is MRI and CT in your institution? And that if the answer is yes, that you do both MRI and CT, why do you do that? And what's the standard way of doing that globally?
Yeah. So really good question. So the reality is usually when a patient presents to ED, got a headache or confusion, they'll get a CT head first. Usually they'll get a CT head first. And if they see a lesion or even if the brain's normal, then they'll move on to MR. There's very few situations where they'll have an MR, patients will have an MR first. If they do have an MR first, for example, maybe they've come as an outpatient and, it's like they're not too unwell, they have an MR first. We don't normally do a CT as well. But if we're not sure, could this be a meningioma? We had a case, slightly different, not a brain tumor, but we had an orbital lesion in a young child, and the patient had an MR because they couldn't, their visual performance had deteriorated, and on that orbital scan, it was really difficult to understand what this lesion could be. And the differential included meningioma and included, other things such as inflammatory lesions or, CNS lymphoma or leukemia. So we did a CT actually, and the CT showed a fleck of calcification. So that gave us that extra evidence that actually this was an orbital meningioma. So I wouldn't say you need to have a CT. Most patients will have a CT, but if they don't have a CT, it can be useful if you're not sure whether something's blood or calcification, or if you're a bit stuck with your differential.
Okay, thank you. There's another question from Dr. Harry. He says, among the conventional MRI sequences, whereby we do sequences like T1 weighted MRI, T2 weighted MRI, and FLAIR, that which sequence is most helpful for detecting tumor infiltration beyond the enhancing margin?
Yeah, so good question, really good question. So I think if you could only do one sequence, I would do a T2. Because the T2 gives you everything, you can see the inner tape of the skull, you can see all the blood vessels, you can see all the extracranial soft tissues, and you can get really, really good soft tissue contrast within the tumor. FLAIR is basically a T2 weighted image. It's just that you're suppressing the signal from CSF. The T1 post contrast, oh gosh, the light's gone off again, but I'm going to wave a little bit just to get some, excuse me, just try and get some light. Yes. I don't want to sit here in the dark. Um, so the T1 obviously will show you the enhancing tumor. You won't see, you will see low signal intensity in the non-enhancing or edema, but it's not as easy to detect. So I think a T2, if I only had one sequence to do, I would do a T2 weighted image.
Okay, thank you. The next question is from Dr. Obasi. She says, if you can throw more light on sodium imaging, the mechanism of action, the indications.
Yeah, so at the moment we're just doing a feasibility study and we're trying to get some funding to do a larger study. So I can't tell you anything about like correlation with histology, or that's what we want. That's the study we want to do. There are some published studies, usually from the US, one in a pediatric population. And what they've been using the sodium imaging for is when a patient's had treatment, had radiotherapy, and they've got a new or enlarging lesion. And they've published that the sodium imaging helps them differentiate true tumor, which will have a high sodium uptake compared to an inflammatory lesion. What I'm actually interested, what I like about the sodium imaging is that you get a whole parameter map for the whole brain. So in these very diffuse non-enhancing gliomas, you can see some heterogeneity within the lesions that could help surgeons, for example, with biopsy and also with radiotherapy planning. But I'm also interested in the fact that there is background sodium uptake in the rest of the brain. And can we use the sodium imaging to understand a bit more about tumor infiltration beyond the visual margin? So that's where my interest is. So if we can get this funding for this study, and if we can correlate with biopsy, then I'd be able to tell you a little bit more about that. But at the moment, I can't tell you about the correlation with histology.
Okay, thank you. The final question before I invite the president of the Neuroradiological Society of Nigeria, Dr. Christiana. Our question is, please, which sequence can one use in monitoring treatment, if not spectroscopy?
That's a really good question. If you have MR perfusion at your hospital, like even DC perfusion, I think perfusion can be very helpful when you're seeing those sort of enlarging lesions, or maybe a new enhancing lesion, and you're not sure whether it's recurrence or whether it's an inflammatory lesion, pseudoprogression. So if you haven't got spectroscopy available, MR perfusion can be really helpful. If you haven't got MR perfusion, I think the ADC, looking at the DWI, can be helpful as well, because usually tumor is cellular, whereas inflammatory tissue is not so cellular. So if you can see low ADC, so we always look at our MR perfusion in combination with the ADC. So if you haven't got MR perfusion, then you could use your diffusion to help you. It's very tricky clinically. I mean, you must have cases like this where you're not sure, has the tumor come back or is it something else? And sometimes we do we get stuck even with all the advanced imaging, and we say, let's just do an early follow-up. So we do a follow-up at 6 weeks just to see whether it's growing bigger or got smaller.
Yeah, thank you so much for the brilliant lecture and for answering all our questions.